Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much, Dr. Mervat and panel for this, inviting me for this elegant meeting. It's always a pleasure and my happiness that I was a trainee in Shams University. I moved to the UK 5 years now, and I'm currently a consultant cardiologist at Greenfield Hospital at University Hospital of Leicester, which is one of the biggest centers in the UK. Today, I'm going to speak about his bundle pacing in heart failure. Is it a real bailout strategy or a real hope for heart failure patients? So I have nothing to disclose regarding this presentation. And my patient today is a 79-year gentleman with history of hypertension who has been diagnosed with dilated cardiomyopathy 6 months ago. He has ejection fraction of 30% on optimum medical therapy and a coronary angiogram showing normal coronaries. So there is no obvious coronary abnormalities in this chap. And he presented to our hospital with worsening heart failure, dizziness, and we done an ECG monitor for him and a telemetry, and it showed that the patient is having intermittent second-degree heart block. So I listed him for an inpatient CRT implant. He's been known to have a normal coronary anatomy, as I mentioned before, and his ECG is showing left bundle branch block, first degree AV block, PR interval of about 260 milliseconds, and QRS duration of 150 milliseconds. So this is his resting ECG, and we can see clearly that the PR interval is prolonged. He has a classic complete left bundle branch block, QS in V1, notched QRS complex in AVL and V6. So typical left bundle, broad QRS complex. So I started my procedure in a standard way to give him a CRT device, left infraclavicular incision, infiltration with lidocaine 1%, cephalic vein access, which I normally start with to minimize the risk of pneumothorax for all the vein. And if the patient have a sizable cephalic, I prefer to keep it for all veins, for all the leads. If not, I use it for probably the LV lead and make an axillary access for the atrial and ventricular lead. So Medtronic capture fixed lead 58 centimeter in a standard right ventricular septal position, and the 52 centimeter into right atrial appendage, normal beginning of a CRT. And then next I go with a 10 command catheter of Medtronic with ambulance left wire and ambulance left diagnostic catheter to Romo wire to cannulate the CS, and they do venogram to check. So this is his venogram, and it's a bit, the catheter is a bit deep, but I normally de-sheath over the wire, and there is no risk of dissection if you are going over your wire normally. And doing a venogram, non-selective venogram in LEO position, there is very small couple of lateral branches, nothing on the posterior or posterolateral, and nothing obviously sizable arteries. Vein, sorry. In REO projection, we got different thing, but no much information given apart from the small lateral branches with nothing seemed to be a good target for LV lead placement. So I decided to take a balloon and do occlusive balloon venogram. And as you can see here, I normally do a prolonged cine acquisition to see if there's any late filling, and there was something which seemed like a posterior branch or a middle cardiac vein. I'm not sure, so I will show that later on. So try to see if I'm missing any branches. I brought the balloon a bit proximal, then another injection, and then even more proximal balloon venogram. I still can't see any posterolateral or lateral branches suitable for LV lead positioning. So I tried to cannulate the middle cardiac vein, and as we can see, it's a very big middle cardiac vein and small posterior tributaries, which might be a target for an LV lead, as we haven't got any other alternative. So I positioned my quadripolar lead into the distal part of the middle cardiac vein. I'm trying to project a bit posteriorly, and all the leads and electrodes that we got here, the very high pacing threshold above 5 volts with phrenic capture. So I tried distal and proximal electrodes, and I couldn't get anything satisfactory at that point. So options we got at this point is either, number one, do we need to abort the procedure? Do we need to list him for a second procedure? Can we call for a different operator? Shall we stay with a dual chamber pacemaker or try different mechanism of pacing, physiological pacing of his bundle pacing or left bundle pacing? So a portion of the procedure was not an option because this patient is having a symptomatic second-degree heart block and dizziness, so we cannot abort the procedure. Second procedure is unlikely to be of any use as we are not missing any equipments and the patient needs to have something to be done. I didn't call her for a second operator because there was no technical difficulty that I cannot personally overcome. So I don't find there is a reason for calling for a second operator. And dual chamber pacemaker remained an option despite the patient is having worsening heart failure symptom. And dual chamber pacemaker will definitely prevent his syncope or pre-syncopal events, but will not improve his heart failure symptom. Therefore, I proceeded for the fifth option, which is his bundle pacing / left bundle pacing as a next step. So the idea of his bundle pacing is not new. It's developed in the early 1970s where some colleagues tried to pace the his region and get a decent capture. However, it was very difficult, challenging. The equipment was not there. And the actual use of his bundle pacing started in early last decade and this decade. So the idea, as we all know, that the His-Purkinje system or the conduction system of the heart starts from the AV node with some interatrial conducting channels to the AV node, and then the penetrating bundle of His travels through the tricuspid isthmus and bifurcate into right and left bundle. And the idea of placing an active fixation lead on the His-Purkinje system, on the His bundle, either on the right atrial side or on the right ventricular side, can actually recruit and stimulate the heart in a physiological way, getting the impulse down to the His-Purkinje tree in a normal way. The question is how a His bundle pacing, how a His pacing lead in that position will correct right or left bundle branch block. It's a matter of controversy, and there is a lot of theories to explain this. Number one is the site of block. So some people think that we place our lead distal to the site of block. So if we go a proximal left bundle branch block and you're pacing slightly distal to the site of block, you can get correction of the left bundle. A second mechanism is output dependent. There is a block to the normal impulse, but if we pace at a higher output, we recruit some of the left bundle fibers. And the last mechanism, which is the most widely acceptable mechanism nowadays, is the His is not one structure. It is like this electrical wire. There is a longitudinal dissociation of fiber. So the fibers which are designed to be a left bundle or a right bundle actually start very early after the AV node. And the His is not one structure. It is a parallel longitudinal fiber. And we base directly the left bundle, right bundle, and the common things all together. So this is the idea of how His bundle pacing can correct left bundle branch block or right bundle branch block. Of course, there are some cases where there is a distal His-Purkinje disease and His bundle pacing cannot correct the left bundle branch block or the right bundle branch block. So the breakthrough, the His bundle pacing, as I mentioned in the last decade, the Medtronic company developed a dedicated tools for the His pacing. So we have the Medtronic Select Secure 3830 lead, which is a 4.1 French lead. It is a 69 centimeter, a bipolar lead, and it has got a fixed screw helix. So the helix is a pre-deployed. This lead hasn't got a lumen, so it's a lumenless lead and delivers through a special catheter. You haven't got a stylet to shape or to position this lead. It should be positioned across the catheter, and it is a steroid eluting lead. This is the structure of the lead, and this is the catheter. So the catheter is called CS 315 His catheter. It got two curves, one proximal curve and one distal curve to point through the septum. And as we can see here, this little deflection at the distal part is to direct the lead toward the septum. It comes with a dilator, and you can use this catheter with a safe sheath, or if you dilate the track with another dilator, you can use it directly, similar to what you do with the CRT catheter. And you go a sideboard to flush and you can give some contrast in case you want to deploy your lead deep in the septum for left bundle pacing and you want to check how deep you are in the interventricular septum. I would like to show you how we do the connection for this His pacing, because it's interesting. You need to have a 12 lead ECG in case of His bundle pacing to notice that ECG difference and differentiate between different output of His pacing. And we normally have, you need to have an EB recording system to see the His signal carefully.
So we've got, are you recording? Yeah. Okay. So we've got PSA on the atrial signal with maximum sensitivity. And then that goes into a jump into our EP barred system. And we've selected our His on poles 5 and 6. Okay. So that's jumped to our pacing PSA. And then this will get connected to our testing cables at the patient, where Dr. Ibrahim will connect up black unipolar to map for a His.
Okay, so the important part here, we have like a Y connection here. The signal, the testing cable, we connect it with this Y connection to the pacing system analyzer and to our EB barred recording system. So we've got the next step is I normally go with the wire to the right ventricle and then put the C315 catheter over on top, and then you got your lead. You just need to protrude the little bit of the tip of the lead and try to map around the tricuspid valve annulus. You can use REO, LEO, and PA projections to show you how septal or lateral you are and what signal you got. So I think His pacing is mainly for EB consultants, for EP doctor, rather than a pacing physicians, because we all know what looks like an A signal, what is V signal, what is an AV signal, and you are on a tricuspid valve. And on a His region, you normally see a His deflection between the A and V. You can also, if you move the bit distal, you can have HV or right bundle branch block V. And we map in a unipolar configuration. So the black is on the tip of my lead and the red is connected to the patient's skin. And I try very gently moving the catheter clockwise, anti-clockwise, and pushing forward and backward, try to map the His region very slowly. And first of all, once we get a His signal, so we have a small a, H signal and V signal, we do our baseline measure. So our baseline measure, we measure the intrinsic QRS complex, which is here 156 millisecond. The HV interval is 80 millisecond, denoting some disease in the AV node, and that's why we saw a first degree AV block on the resting ECG. And the pacing and the His signal to the end of the QRS complex. This is the 3 measures I normally do to start with. And then we start pacing. Always start at the highest output, 10 volt or 8 volt, and come slowly down. And we notice the response to our pacing. So the response to our pacing could be one of 5 things. Either we go an atrial capture, or ventricular capture, or selective His bundle capture, non-selective His bundle capture, or no capture. This is the 5 options you got when you start pacing. Option 1 is not available if the patient got atrial fibrillation. And what we have when you got a pre-existing right or left bundle branch block, things becomes more complex. So you can have selective or non-selective His pacing with complete, partial, or no correction of the bundle branch block. So easy thing first, if you go right ventricular capture, you see on your His electrogram, this is a 12 lead ECG. On your His electrogram, you have the pacing spike followed by a broad QRS complex, left bundle configuration, and the QRS is 200 milliseconds. So there is no way you are pacing the His, whether selective or non-selective. This is pure right ventricular capture. To demonstrate the difference between selective and non-selective His pacing, I will give you another example, another case, because the first patient we are doing has got left bundle branch block. And as I mentioned, with bundle branch block, you got totally different options and you cannot differentiate between selective and non-selective easily. So on this example, this is a patient with atrial fibrillation. There is a His V, and we've done our measures. Intrinsic QRS complex 112 millisecond, HV is 52 millisecond, and pacing spike till the end of the QRS complex is 164. So we start pacing at higher output, 10 volt, and all we see here is nice and narrow QRS throughout the 12 lead ECG. If we compare it with the sinus rhythm, you got 12 out of 12 matching. So the 12 leads is exactly pacing similar in sinus rhythm or in own rhythm and paced rhythm. And number one criteria, his to the QRS complex is identical to pacing spike QRS complex. So the duration is 54 milliseconds from the pacing artifact till the beginning of your QRS complex. This is exactly the same as pacing spike till the beginning of QRS complex. And the second criteria for selective His bundle pacing, intrinsic QRS is identical to the base QRS. So 12 lead matching, this is a base rhythm and intrinsic rhythm, and they are both the same in duration and morphology. Third criteria, there is isoelectric line between the pacing spike and the beginning of QRS complex. If we all look at this ECG tracing, there is pacing spike there, nice isoelectric line before the beginning of QRS complex. And the fourth criteria, there is the local ventricular ectogram is discrete from the pacing spike. So if you look here, this is a pacing artifact, you have some baseline, and you have another ventricular EGM. If I move to the next slide, when we come down on our pacing output, we noted this different in ECG morphology. So again, still QRS complex is not very broad, clearly not right ventricular capture. Pacing spike till the end of the QRS complex is 166 milliseconds. This is exactly the same as the intrinsic conduction. So from pacing spike or from his till the end of QRS complex is the same. Pacing spike till QRS complex is 0. So we have a pacing spike and the QRS complex start immediately after the pacing spike. Number two, paced QRS complex is broader than the intrinsic QRS, and we have some delta wave similar to a septal accessory pathway like septal WBW. And the third thing, pacing spike to the end of the QRS complex is identical. And number four, local ventricular electrogram is captured by the pacing spike. So if you look at the wrist, this red His electrogram, pacing spike, I can't see a discrete ventricular electrogram. They are both captured together. So I show you the difference between both. At higher output, we got selective His bundle pacing. At the lower output, we got non-selective His bundle pacing. So why we have selective and non-selective His bundle pacing? This interesting paper by V.G. Ramon group presented in JACC in 2018 found that when we study the anatomy of His bundle, there are three different discrete anatomical features. The first type is 40% of people got His running in the membranous interventricular septum. About 1/3 of population got the His running in the muscular interventricular septum, and there is a muscular sleeve around the His Purkinje fibers. And the third type, the His is directly under the endocardium, which is called naked His type of anatomy. On this second type, for example, you will never get a selective His bundle pacing, because whenever you pace here, you will have some local myocardial capture. So all you get here is non-selective His bundle pacing. For this type, you probably will have some selective and non-selective His pacing. And for the third type, you can get selective His bundle pacing only. So we go back to our case, the patient who had a left bundle branch block. When we started pacing him at the His pacing, we noted this nice and narrow QRS. So basically, the pacing spike till the beginning of QRS complex became 60 milliseconds. So we corrected some of the first degree AV block or the AV nodal conduction problem he had. Intrinsic QRS complex is less than 100 milliseconds, which is great. It was more than 150. And from pacing spike till the end of QRS complex became 160 if we compare it to 240, which we had earlier. So we could narrow the QRS complex, correct some of the first degree AV block he has got. And we couldn't have non-selective capture. So all we got is selective His pacing, and the threshold was less than 1. So this is his intrinsic 12 lead ECG, and this is his paced 12 lead ECG. And to be honest with you, I feel very happy when I see such a nice ECG. I don't think with any CRT therapy you can go QRS complex less than 100 milliseconds, very normal and very physiological ventricular activation. There is another example for a case done by Dr. Hong and published in the Heart Journal last year, where there was a His pacing in a left bundle branch block. At a low amplitude, you got his pacing, nice isoelectric line, but we couldn't correct the left bundle. At a higher output, they got the narrow QRS complex at 1.5 volt at 0.5 millisecond. You know that there is some proximal his left bundle block. At a smaller output, we captured the his Purkinje system, but at a higher output, we could recruit some of the blocked left bundle potential and get full correction of the left bundle branch block. So how we fix this lead? This lead, as I mentioned, got a screw, an active helix. So what I normally do is 4 to 5 turns with your right hand clockwise, 1 turn, hold with your left hand. Look at my left hand, please. So 4 turns or 5 turns, and normally you get the screw, the lead screwed into the septum. And then I need to retract my catheter a little bit, fix the lead and retract the catheter to expose the second ball of the lead, and then we test the lead in bipolar configuration. Importantly, if your lead displaced, try not to position it immediately. Have a look on the lead, because what we found is sometimes after the first placement, you got blood clots or tissues, myocardial tissues on your lead. And if you try to reposition it back and screw it, it's either not fixed in a position or you can't pace from it. So give it a good cleaning, good wash before trying to reposition it again. And then after you got a nice, decent signals and you are happy with your parameter, slitting the lead. So I have with this, you don't use the universal slitter. We normally use this pestle one because the lead is tiny. It's 4 French lead. And this slitter has got a groove. So you get your lead into the groove, fix your right hand and slit with your left hand. So the trick I mentioned earlier, and I put a star on the first thing. This patient, I meant to be doing a CRT for him. So I used cephalic for all the 3 wires. But what happened here, because the catheter has got 2 deflections, so the second deflection acts as a hook. So when I was slitting, I displaced the atrial and ventricular lead. So this is a mistake I have done in this case, which I don't do. That I advise everyone, if you're going for his bundle, do separate puncture, either axillary or use a cephalic for one lead, for the his lead, for example, and axillary for the others, or vice versa, because the double curve on the his catheter usually retracts the lead if you are trying to slit them. It wasn't a difficult job to reposition the 2 wires back to normal position. It took 2 minutes to put them back in place. And this is the final X-ray position for the his lead, the right ventricular lead, and the right atrial lead. In this particular case, it was one of the early cases I done, so I used the RV lead as a backup because I wasn't 100% sure that his lead will function properly, but it will be an option to put a dual chamber pacemaker with an atrial lead and his lead, and you don't need to have another RV lead in this particular case. And look at his ECG, final ECG, it looks amazing. So you have a nice pacing spike, isoelectric line, narrow QRS complex of about 90 milliseconds, full correction of the left bundle. And if you remember this initial ECG and the comparison, this is how it looks like. First degree AV block has corrected, QRS complex became narrower and narrower, and that's it. So discussion point, is this his bundle pacing and this his bundle strategy, is it a bailout for patients who have got failed LV lead placement for any reason, failed CRT, no target veins, high threshold, phrenic capture, displacement, or non-responder? Or could the his bundle pacing be an alternative in the future for left bundle pacing, for CRT, for patients with heart failure and left bundle? A second group of patients, non-left bundle. We all know that the response rate of CRT for right bundle branch block and interventricular conduction delay is very close to 50%. And a lot of patients doesn't respond to CRT if they haven't got a left bundle branch block. What about also patients with first degree AV block? And the third group of patients are those who have atrial fibrillation, flutter, or resistant SVT, where you consider doing an AV node ablation and implanting a dual chamber pacemaker. So I'm going to present a couple of slides on these indications for his bundle pacing in this different cohorts of patients. So the first paper is by Dr. Hong et al. That was published last year in the Heart Journal. They basically tried to implant a his bundle for anyone with heart failure and left bundle branch block. And in a 75% of patients, you can go a full correction of the left bundle and narrow QRS complex. They followed the patient for 3 years. And I'm very glad to see that the baseline ejection fraction was 32%, improved to 48% in 3 months. And this improvement continued throughout 3 years. So 3 years of follow-up, and the ejection fraction remained mean ejection fraction of 55%, which is very, very reassuring and very good result. I don't think a standard ECG do that except for super respondent group. A second group, a second paper I would like also to highlight, Dr. Wong and his colleagues also published this paper this year in the European Heart Journal, benefits of permanent his bundle pacing with AV node ablation in patients with atrial fibrillation and reduced or preserved ejection fraction heart failure. And they included 52 patients. They could implant the his lead in about 42, which is 80%. And if we can see here, the ejection fraction was about 30% baseline, and at a 1 year of follow-up, it continued to gradually improve to about 50%, and there was statistically significant difference in ejection fraction among this patient. That's what made the guidelines, the European Society of Cardiology guidelines said, for patients who have supraventricular tachycardia, flutter, or fibrillation, AV node ablation with subsequent pacing, a latent-based strategy, either with biventricular pacing or his bundle pacing is recommended. This is class 1. If you got tachycardia-induced cardiomyopathy, you shouldn't be doing an AV node ablation and dual chamber pacemaker. You should be going for a CRT or his bundle pacing. There was a couple of papers to compare the difference between his pacing versus CRT pacing in people with left bundle branch block. So the first paper by Todd Shedlon and his group published in 2015 in Heart Rhythm Journal, they done a crossover trial. The problem with his bundle, it's a new subject. There is no big randomized controlled trial. This trial was a crossover trial. So 21 patients, they implanted a classic, a standard CRT, an extra his lead, and through a Y connection, they could either pace biventricular pacing for 6 months or his bundle pacing for 6 months, and they compared the outcome. So in 6 months' time on either group and after crossover, the ejection fraction improved both in his pacing and biventricular pacing. The quality of life showed significant improvement in the quality of life questionnaire. NYHA class improved and 6-minute walk test improved as well. And there was no significant difference between both groups. The first randomized controlled trial to compare between standard CRT versus a normal his bundle pacing was the his sync trial. It's a very recent, published last year in the Heart Rhythm Society. It was only also for 40 patients only, 20, 21 in each group, and they compared a standard biventricular pacing versus his CRT. Interestingly, for the his CRT group, all patients got improvement of QRS duration from mean of 174 millisecond to 120 milliseconds. So on average, you got 50 millisecond shorter QRS duration, unlike the CRT group where there was no statistically significant difference between the baseline and the based QRS. Ejection fraction improved in both groups. And when they compared the his group versus the biventricular pacing group, there was non-statistically significant difference. Despite, to be honest with you, the number is small and the follow-up was for only 1 year. So I suspect if we done a prolonged follow-up or a larger cohort of patients, this difference might be statistically significant difference. So the echocardiographic respondent in the his group was 80% compared to 57% in the BIV group. And the median change in ejection fraction was 5.9 to 7.2. And again, non-statistically significant difference, despite there was a statistically significant difference in the reduction of the QRS duration. So we all know that his pacing could improve the QRS duration better than a standard CRT. What about his bundle pacing in patients with right bundle branch block? This was, again, a retrospective study from 5 different centers, a paper published by VG Ramon Group in Circulation 2018. And they collected about 70 39 patients who had right bundle branch block and his spacing. So again, QRS duration shortened from 150 to 125 millisecond, and ejection fraction improved from 30 to 39%, and the response was 76% echocardiographic respondent and 69% clinical 74 and 69 on echocardiographic respondent to CRT with his pacing, which is this figure. I'm sure we all agree this is greater than any CRT trials with right bundle branch block. The last paper is whether his pacing could be a routine clinical practice. Is this something that we might be looking in the future? Everyone got his pacing instead of dual chamber pacemaker, even if they haven't got a heart failure. An interesting paper published by V.J. Ramon and his group in 2018, they could convince a sister hospital. So two hospitals, one implanting pacemaker for every coming patient and one hospital implant his pacing for every coming patient, regardless the indication of pacing. And the primary outcome was the difference in this heart failure hospitalization or need for upgrade to a biventricular device. And the event-free survival was a statistically significant difference in favor of the his pacing. And this difference was obvious and significant if the patient required more than 20% ventricular pacing. For those who require occasional pacing or less than 20% pacing, the difference in the primary outcome was not statistically significant difference. So to conclude my study, his pacing is a definite bailout strategy to CRT in certain conditions. For example, non-respondent, no target for LV, recurrent displacement, phrenic nerve capture. His bundle pacing also could be used in patients with atrial fibrillation or any form of supraventricular tachycardia undergoing AV node ablation, particularly with any degree of tachycardia-induced cardiomyopathy. The third conclusion is his pacing is a good alternative to conventional CRT, particularly in non-left bundle patient, and might be actually superior. Of course, we need more evidence from randomized controlled trials and larger cohort of patients, and would be the future for his pacing instead of normal pacemakers for everyone. Times only will tell, and we can't conclude. So thank you for listening, and I'm happy to answer any questions if you have.